No, you don't need those. Please don't memorize them, because every once in a while I forget some of the things in the vaccine schedule. But this is a copy of the vaccine schedule, so the vaccines is recommended that you give children as part of their regular vaccine schedule. There's obviously a lot of different types of disease on here, that's why we give the vaccines against them. But there are, just to kind of show you, there's a lot of things we vaccinate against. We talked about this already, so different ways some of these organisms can be transmitted to us. So direct contact, so usually if we're talking about direct contact, we're talking about droplet transmission, droplet, as opposed to like aerosolized droplets. Droplets themselves are bigger than aerosols. They tend not to travel as far because they're bigger. So if you are a meter or less away from somebody and you sneeze, you probably sneeze in the face, so even though you're not making direct physical contact with them, you blew snot in their face, so that's considered direct, even though, yeah. And then obviously like direct body contact, so things like shaking somebody's hand, or kissing, or sexual contact, all things like that are considered direct contact, obviously. And then there's a bunch of indirect things. Vectors, we talked about those. Can somebody give us some examples of like vectors? Where's some vectors?
The kissing.
Mosquitoes, the big one, ticks, things like that. Those are vectors. So they're going to transmit a living organism. Usually those vectors tend to be required for that microorganism's life cycle for whatever reason. We tend to be accidental dose, so it's just something the vector bites us, but we're not really required for that microorganism's life cycle. And then you have fomites, which you talked about. So those are inanimate objects. So if somebody sneezes on their hand, touch the doorknob, you go touch the doorknob, then you touch your face. The doorknob's a fomite, so anything that's inanimate. Parental transmission is like through needle sticks or kind of some kind of a Sharps injury. And then vehicles are when you're getting something through like food or water. So like cholera from water, hepatitis A from food, things like that. So we talked about all these. All right, so let's talk about diphtheria. So diphtheria, that's a gram-positive. Cranobacterium diphtheriae is the microorganism that causes diphtheria, and pretty much the only thing that makes Cranobacterium diphtheriae virulent is the diphtheria toxin. That diphtheria toxin comes from a bacteriophage, so you could in theory come across the Cranobacterium diphtheriae isolate if it has not been infected with that bacteriophage that carries the diphtheria toxin. It's not going to cause diphtheria. So there are a lot of isolates that have that. But theoretically, there's a chance that can happen. So it's a lysogenic phage that carries that toxin, inserts that phage DNA, they includes the toxin into the bacterial chromosome, and then it becomes a toxigenic strain. About 5 to 10% of the people that get diphtheria actually the toxigenic strains, so that means the ones that actually get diphtheria toxin, about 5 to 10% of those people actually pass away from it. It's usually transmitted through droplet transmission. The R naught for it is 6 to 7, so every one person can get 6 to 7 people. So that's not a real high R naught. Usually kind of anecdotally, kind of like a rule of thumb is anything above 10 or 12 we start to worry about, because that's indicative that it's more aerosolized. Anything less than 10 or 12 tends to be a little more difficult to spread. Does that make sense? The vaccine for it is the D and the DTaP, or the, that's, what's the type? We don't talk about vaccines in here much. Okay. So, the D and DTaP stands for diphtheria toxin. So what that is they took a toxin, they inactivated it, and it's a toxoid vaccine. So they take the inactivated toxin and inject it into you. Because really, the only thing, like I said, that makes you sick with diphtheria is the toxin itself. The microorganism doesn't really, if it's not making diphtheria toxin, it doesn't really do anything to you. So the vaccine's actually against the toxin. So in theory, you could be infected with Cranobacterium diphtheriae, and the vaccine's not really going to do anything for you. It's just inactive. It's just your immune response is going to make antibodies against the toxin. So it protects you, but it's not actually getting rid of the bacteria. It's protecting you against the toxin the bacteria makes. The same thing is true for tetanus. That's what the T is. It's also an inactivated toxin. So it's protecting you against the tetanus toxin. And then A, anytime you see the lowercase a in these vaccines, it usually stands for acellular. And the P is for pertussis. We'll talk about pertussis here in a little bit. So pertussis causes whooping cough. The way we vaccinate against pertussis is it has a lot of carbohydrates on the outside of it, part of its capsule. So what your body sees is those sugars on the outside of the bacteria. It doesn't see anything else. Remember, I think before I told you the immune response was really, really good at recognizing proteins, really, really crummy at recognizing sugars, and that's what's on the surface of this. So that's what's in the vaccine. With that said, that component of the vaccine is kind of crummy. So you vaccinate against it. It protects you against pertussis for up to 7 years or so, sometimes less, sometimes more, depending on the immune response of the person. And then after that, you can get whooping cough again. So there's many people, my brother-in-law is a pharmacist, my wife, they've all been vaccinated against this, but they've still got pertussis. What happens is that vaccine response wanes, so you have to have a booster. Every patient has this vaccine, and that'll protect 50% of the time. This is what diphtheria looks like. Sometimes you'll see this referred to as straining angel. What happens is you get a pseudomembrane formation across your respiratory tract, and people essentially suffocate to death. What is that pseudomembrane? Fibrin, dead bacterial cells, dead red blood cells, dead white blood cells. This is the kind of mix of all the things that you'd expect to see in an infection. That happens in the respiratory tract, and it can block your airway, and you can suffocate. This is what it looks like. It can look like this, where it's more white. Sometimes it takes on a grayish appearance. Usually it's either the pseudomembrane is usually white or gray. There is a possibility of cutaneous diphtheria. It is extraordinarily rare. Usually what happens is people get that secondary to some kind of an insect bite, because you find this sometimes out in the environment. Sometimes you'll see it secondary to somebody having scabies. Sometimes you'll see it secondary to somebody brushing up against something and just getting like a graze on their skin. But it is very rare. It's usually some kind of a puncture wound, but it doesn't necessarily have to be. This is what it looks like. It's kind of a punched out ulceration. Does everybody know what a biopsy punch looks like? I always ask that, I never bring one in. So a biopsy punch, at the end of this little handle, you have a little cylindric thing that's made out of metal, and at the end of the cylinder it's sharp, so you can punch down in and take a biopsy sample from somebody. So it looks like somebody took a biopsy. You also see this kind of peeling away of the skin around this punched out ulceration. If you would ever see cutaneous diphtheria, that's the vast majority of the time what it looks like. Punched out ulcer, skin peeling around the outside of that ulceration, and it's usually erythematous, which means it's red. That's kind of classic what cutaneous diphtheria looks like. Okay, let's go to the other component of that vaccine. So pertussis. So pertussis, the main population of people that are going to be severely affected with this is going to be usually infants. We talked about this, I think, before. They played that video, didn't put the clip, what they sound like. So they're going to gasp for air. R naughts, 12 to 17. That's another reason that this spreads so easily. So the R naught is going to be more aerosolizable. One person may fall to 17 sick, so it spreads easier. And also the vaccine doesn't cover as well as the other components of that vaccine for diphtheria and tetanus. Children less than 5 years of age, newborns can die quickly from pneumonia and toxemia. So toxemia, anytime you see emia, it means it's in the blood. If it's viremia, you have viruses in the blood. If it's bacteremia, there's bacteria in the blood. If it's toxemia, there's toxin in the blood. If it's fungus, there's fungus in the blood. Anytime you see emia, it's something in the blood. Adult and adolescent carriers around newborns are often the source of infection. This is why we always make sure that anybody that's going to be around young children, like infants, are always vaccinated against this, because it can cause a very severe and not fatal disease in infants. The causative organism is Bordetella pertussis. This is the same genus that causes kennel cough in dogs. So the Bordetella, I always forget the species name. Bordetella bruncoseptica. Yeah. So Bordetella bruncoseptica causes kennel cough in dogs. So it's a respiratory disease process, so you get that. Because we're working in the vet's office. Produces adhesins and toxins, and again, the component of this that protects you against is that acellular preparation of the pieces and parts of Bordetella pertussis. But since it's acellular, it doesn't last as long. Usually the way this works is you have colonization, which we talked about. So one of the first things that's going to happen, and pertussis are really good at doing this, is it's going to make a bunch of adhesins attached to usually respiratory tract, causes the symptoms of whooping cough. At this point, when it's actively colonizing, antibiotics work. After you have enough Bordetella pertussis, the amount of toxins that are being made by that, because you have more bacterial cells, goes up. When you get into stage 2 of this, so longer on an infection, what happens is you don't really see as much bacteria. What you're seeing more of the symptoms are because of the toxins there, not necessarily the bacteria. Because your immune system is not too terrible about trying to get rid of this bacteria, but the toxin kind of remains. So as this disease process progresses, if you give somebody antibiotics, it doesn't do anything because there's not a lot of bacteria there to kill. It's the toxin that's causing the problem. Does that make sense? So there's a few different infectious diseases that kind of act like this. It's just like, well, it's the toxin causing the problem now, so if you give antibiotics, it's not going to do anything because it's not going to impact just the toxin being there. On to another one. So there are a few different microorganisms, a few different bacteria, I should say, that cause meningitis, bacterial meningitis, Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitidis. You tend to see these organisms associated with the nasopharynx, so they're normal flora. So you can be colonized with these. What tends to happen sometimes is somehow they find their way out of your nasopharynx and they make their way to your blood-brain barrier that covers your central nervous system, and they cause inflammation. As those cells in the blood-brain barrier become inflamed, the bacteria gain access into your cerebrospinal fluid that bathes your spinal cord in your brain. And when it gets in there, there's, yeah, I know it's really hot here. When it gets into your central nervous system, I don't think I talked about this. You don't have a lot of immune cells in your central nervous system, so there's nothing to really stop it. So it can cause a really fatal infection. So it can cause things like meningitis, encephalitis, meningoencephalitis. Usually it starts out as a sore throat. As it progresses to meningitis, you get stiffness in the neck. And there's some different ways you can test for that stiffness in the neck. You get vomiting, potentially high fever. And usually the way the bacteria actually got there is through the bloodstream. Bacterial meningitis is usually referred to as septic meningitis as opposed to aseptic meningitis. Usually when we're talking about aseptic meningitis, we're referring to a viral infection, a viral meningitis. Reason for that being is you can take a culture of somebody that has bacterial meningitis, say from the cerebrospinal fluid, you're going to get growth on a plate. If you take a culture of cerebrospinal fluid so that has viral meningitis, you're not going to get growth on a plate because viruses need hosts to grow in. Try to grow on like a tricky soil on a plate, you're not going to get anything. So that's one of the reasons it's referred to as aseptic, because you won't get growth return. Essentially. Culture, you can culture a cerebrospinal fluid. There's a few different things you can do for that. I usually don't talk about this until infectious diseases, but one of the things you can also do is you can look for the amount of glucose that's in the cerebrospinal fluid. If the amount of glucose goes down, it's going down because there's something in there metabolizing it. What do bacteria like to use? They constitutively express genes for the metabolism of glucose. So glucose is going to drop with bacterial meningitis. It doesn't really drop as much with viral meningitis because they're not metabolized. Other things you might see is you'll see white blood cells in cerebrospinal fluid. Well, remember I said you don't see a lot of white blood cells in your cerebrospinal fluid? They can get in through the same spot where the bacterial cells cause inflammation of the blood-brain barrier. So if you catch a bunch of white blood cells in cerebrospinal fluid, they found their way in there somehow. And usually the way they found their way in is not a good way. It's because there's an infection, there's an active infection. Some more simpler things actually that are more, I guess you could just say mechanistic, is if you look at cerebrospinal fluid, usually it's kind of a clear to like a champagne-ish kind of color, kind of like a real light yellow, if not clear. So if you do a spinal tap on somebody and take a little bit of their spinal fluid, it should be clear. If it's turbid, it usually means there's bacteria growing. What happens is essentially the cerebrospinal fluid becomes like the broth culture that we grow up in here. So you know how it starts out clear, but then I gave you little broth tubes, it looks cloudy. The cerebrospinal fluid is the medium. One of the other things that's a little bit easy, I think, at this point for y'all to understand this, is you measure something called opening pressure. So when you stick that needle into subcutaneous flexor cerebral spinal fluid, sometimes there's so much gas in there, it'll make like a it'll make a puff. You can measure how much gas is coming off of that, what the pressure is coming off of that, what a bacteria make when metabolize, gas. So you can measure all that stuff. Those are all telltale signs of bacterial meningitis. Haemophilus influenzae type B, there is a vaccine for that. That is referred to as a typable Haemophilus influenzae. Typable means that it has a capsule, and you can type it. What has happened, and I don't have this graph up here, is there used to not be a vaccine for Haemophilus influenzae. When they started giving out the vaccine for Haemophilus influenzae, the amount of Haemophilus influenzae type B strains decreased a lot. Now, if you see somebody with Haemophilus influenzae meningitis, there's probably ones that's non-typable, so it's for the ones that the vaccine's not against. So it's the ones not capsule. That's all that. And then you treat this with antibiotics. When you treat these people with antibiotics, you have to be careful because all the antibiotics don't penetrate into the blood-brain barrier to get the central nervous system. You have to make sure they have the correct penetration. Just like white blood cells and bacteria usually can't get in there, drugs can't get in there necessarily either. Now, about 10% of people die from this, 20% of the survivors have serious disabilities from it. There are vaccines against different components, different, I should say, strains, I guess. There's serogroups of these different meningitis strains. A, C, Y, W135, you don't even know them. A is one of the main ones. Menactor vaccinates against that. B, you see a lot in Europe and Asia. There's a vaccine against that. You don't even know them, but there's vaccines against some of these. In the United Kingdom, one of the main ones you saw actually killing college-age students primarily, because it spreads easily in the dorms. You know, a lot of people close proximity to each other. Was Neisseria meningitis. It was a serogroup B, I believe. In the United Kingdom, they came up with a vaccine for that. They started giving out that vaccine to try to keep people from dying from that Neisseria meningitis infection. It worked very well. The problem with it is the amount of money it took to try to vaccinate everybody against that bacterial meningitis cost more money than just if some of the people died. So they stopped giving. It lasted a long 2 years, if I remember correctly. And there was like, it's cheaper if just like 10 people die than if we try to vaccinate everyone else. So that is where the money comes into it at, which is extremely unfortunate, but that is what happened. Y'all still have to take it. You have to have a meningitis vaccine in the dorms, right? That goes up and down. Sometimes I ask classes that, and they're like, no. And then other times it's like everybody says yes. I don't know. Some places enforce it, some places don't. I know I had one before. Okay, so on to some different streptococcal diseases. One of the main causative organisms of streptococcal kind of illness in people is going to be Streptococcus pyogenes. That is considered group A strep. It has antigens on its surface with Becca-Lansfield antigen group A on its surface. Those are beta hemolytic, which means they launch red blood cells, and those are usually the ones that cause strep throat. We talked about this before. I had strep throat. Why do I keep on getting strep throat? Should I be immune to it? There's like 20 or 30 different kinds of variants of strep pyogenes. So unless you got the exact same one twice in a row, which never has to happen, you can get strep throat a lot. What can happen sometimes is some of those Streptococcus pyogenes strains get phage converted. So they get infected with a bacteriophage, and that bacteriophage carries on erythrogenic toxins. And if you come across one of those Streptococcus pyogenes strains that has been phage converted, it has the potential of causing scarlet fever. Most people, even if they come across one of those strains, don't get scarlet fever because they go get antibiotics before it progresses into that illness. But there is a chance that if you come across one of those, you can get scarlet fever, not just strep throat. We'll talk a little bit what scarlet fever looks like. And then there's different kinds of skin infections. You tend to see strep throat in the winter and spring, usually more temperate climates, not necessarily down here. The rules don't necessarily apply here. And skin infections you tend to see more in the summer. We'll talk about a little bit about what those are. In the wintertime, if you're up north, what happens is your respiratory tract tends to dry out a little bit because the humidity is lower. Your respiratory tract dries out, when it's less humid, it opens you up to different kinds of upper respiratory tract infections. Is usually when you see it during that time of year. This is what strep throat looks like. Large lymph nodes, you see some kind of pyogenic kind of exudates. Fancy words to say, it looks like there might be a little bit of pus there. Droplet transmission by saliva and nasal secretions, 2 to 4 day incubation, and then you have sore throat, inflammation of the tonsils, and just general kind of symptoms you expect of having a sore throat. Lymph node enlargement in the throat. If it progresses and it was a strep pyogenes strain that's actually been phase converted with an erythrogenic toxin, you get something that looks like this. Sometimes you'll see this referred to as scarlatina. You get something called strawberry tongue. Why is it called strawberry tongue? Because the tongue looks like a strawberry. That's from that erythrogenic toxin. You can get this rash usually across the chest that looks like this. That's another thing that's from that erythrogenic toxin. Actually, there's a couple of erythrogenic toxins, but that's what was from. That erythrogenic toxin causes damage to usually capillaries. It causes them to leak a little bit, and that's where the rash comes from. Sometimes you can get desquamation of the feet. That's what that looks like. Desquamation just means that the skin starts to peel. So that's all things from scarlet fever. If you remember, we talked about first, second, third, fourth disease, all those ones. This scarlet fever is second disease. And again, there are some streptococcus pyogenes strains that do carry those toxins. If you've been exposed to one of those strains, there can be some things that happen after you even got rid of the strep throat. You can have glomerular nephritis, so that's going to impact the kidneys. So you have antigen antibody complexes essentially clog up the kidneys, and your immune system might even start targeting the kidneys. Why is that? Because there's proteins on the surface of streptococcus that look a lot like proteins your body makes, and you start to get cross reaction with those things even when the infection's gone. Those proteins, some of those proteins are referred to as M proteins. M proteins are usually anti-phagocytic. Why are they anti-phagocytic? Because your white blood cells, like your macrophages, don't necessarily recognize streptococcus because those M proteins on the surface look like us. So they don't engulf them or phagocytose them. M actually stands for mimicry, so they're M proteins. There's about 80 different M proteins, so it's got a nice little repertoire of different proteins some of these strains can make. The M proteins are one of the main reasons for rheumatic fever, so that's when this is actually impacting your heart valves. So that's after the infection, the immune system's doing this. So this is all autoimmune after the infection is gone. So not pyogenes, another one, streptococcus pneumoniae. So streptococcus pneumoniae is one of the ones that doesn't have a root. So there's different roots of streptococci, A, B, D. Streptococcus pneumoniae doesn't have a Langsfield antigen on the surface, so its root, no, doesn't have a root to put it in, it's the same thing. It has a capsule toxin, multiplies in the lung, can cause pneumonia and meningitis. This is another one that can go to the respiratory tract and over to the central nervous system. There's some different vaccines for it. There's a pediatric vaccine that's against 20 different strains called Prevnar 20. And then there's another one we usually tend to use in adults that is called PPSV 23. I'm not talking about this at all, so I'm just going to tell you this. So the reason you use the different vaccines typically in different populations of people. So the pediatric patients, so remember we talked about this, the capsular polysaccharides, your immune system sucks to recognize them. It's not going to recognize them. So what happens for the pediatric vaccine is you don't have a real large immune repertoire when you're a little kid. So your immune system has difficulty kind of recognizing a lot of things anyways. So they take these capsular components and they conjugate them to something else that your immune system can recognize easier. So it's called a conjugate vaccine. So it's a piece, part of a protein, something that your immune system can recognize. When it recognizes that thing that the capsular antigens are conjugated to, it also recognizes a little bit of that capsular antigen. So you get a little bit of reactivity from that too. So that's a conjugate vaccine. we use that for little kids. In adults, you just give them capsules because immune response isn't great against it, but you have more immune response when you're an adult. So that's why you use one versus another versus kind of age. And they protect against similar things. The adult one protects against a few more strains, but ultimately pretty similar. Anytime you see anything with a vaccine, talking about vaccines here on Wednesday or next week, I don't remember. Anytime you see something about valent, 11 valent, 9 valent, 7 valent, anything about valencies, that means how many different strains the vaccine protects against. An 11 valent vaccine is going to protect against 7 different, or 11 different isolates of strep pneumonia. 9 valent against 9, 7 valent against 7. That's all. Invasive cases of group A strep, Streptococcus A, cause about 11,000 to 24,000 cases annually in the United States, 12 to 1,900 deaths. You don't need to know the numbers. They change a little bit from year to year, but they tend to stay kind of around that range. They can cause more flesh-eating infections like necrotizing fasciitis. There's going to be more penetrating infections going all the way down through the skeletal, to the skeletal muscle, pathetically. They can actually get into the skeletal muscle and start to degrade it as well, and potentially even into the adipose tissue. They make a toxic shock-like syndrome toxin. That's that lipogenic toxin we talked about. Again, that causes the capillaries typically to leak. The capillaries leak, that can drop the blood pressure. That's why you see blood pressure drops sometimes in people that have necrotizing fasciitis. It can lead to multiple organ failure, can lead to high fever, can cause a long-lasting infection. We talked about some of these things before, so there are a lot of different things besides streptococci, or group A strep, I should say, they can cause necrotizing fasciitis. Staph aureus can cause necrotizing fasciitis. Vibrio vulnificus, which is one of the ones you might be a little more familiar with down here because you see it in a marine environment. So this is like somebody goes out and they walk into the water and like one of the riprap rocks, maybe they get a little nick off of that and then they get a really nasty infection from it. So most likely, there's not from Vibrio vulnificus, it's probably from a different Vibrio species. But vulnificus tends to be one of the more prevalent ones, at least here. Acinetobacter, the examples I gave you last week. These can cause some really penetrating, if not fatal infections. Group A strep can also cause some other kinds of infections. They can cause impetigo. I think most people have seen impetigo, especially if they did it around little kids, or maybe when you're a little kid you had it yourself. Causes these kind of like honey-collared pustules, and they itch really bad. The kids scratch and then they spread. That's impetigo. It can be caused by strep. We're seeing an increase in the number of cases that are actually from Staphylococcus now. The problem with that is strep is a lot easier to treat sometimes than Staph aureus, because Staph aureus you can have MRSA. So if you have methicillin-resistant Staph aureus causing impetigo, that could be a problem because it doesn't occur very often, and most people don't treat it like it is drug resistant. Most people, if a little kid goes into the doctor and they see they have impetigo, they give them some kind of a topical, like Puricin or something, and they want on their merry way. The problem with that is as we see an increase in the occurrence of Staph aureus causing impetigo, you might also see an increase in the number of those isolates of Staph aureus that are drug resistant, and then a lot of those typical therapeutics we treat them don't work anymore. We haven't really got there yet, but we might eventually. They can cause, again, this impetigo. Those are just kind of superficial, but they're anything will penetrate down to the muscle. Another one that you might not have heard of that strep pathogens can cause, staph can cause this as well, is a condition called erysipelas. Erysipelas is going to be a little bit more penetrating. It can be rapid, short, and severe. It can even get down into the lymphatic system. For whatever reason, over the past 40 years, we've seen a change in the way that looks. Most textbooks show this on the face. You get this erysipelas on the face. What we see now is we see more cases of this in the limbs. It's just something that's changed over time. No one knows why. Most cases used to be on the face, but now you see it on the arms and usually the arms and so on. This is what impetigo looks like. Usually it's kind of more honey-collared than that, kind of like a yellowish blister that or pustule that itches really bad. If some of these conditions are caused by Staphylococcus, Staph aureus is in fact a beta anaerobe, catalase positive. So what's catalase do? Anybody remember what catalase does? What's it break down into what? Hydrogen peroxide into water and oxygen. Good. Normal inhabitant of the respiratory tract, skin, intestine, vagina, Staph aureus is normal flora. Everybody has a bunch of Staph aureus on it. It also makes coagulase. We talked about coagulase, I think, in here a little bit. But organisms that make coagulase, what they do is they start to rob your body of fibrin. They hide out inside fibrin. Your immune system can't see it. And then when they reach enough of a quorum, they stop making coagulase and they make things that will break down fibrin so they can spread, like streptokinases and things like that. They can produce biofilm. This is one of the main ones you see associated with hospital-acquired infections is Staph aureus. Why is that? Again, because everybody carries that as normal flora, and you are in the hospital, and those Staph aureus strains are exposed to a bunch of different antibiotics, and you're selecting for the ones that are the really nasty Staph aureus strains, and people become exposed to them. Some of these staphylococcal isolates can make toxic shock syndrome toxin. That's referred to as TSST. There are two, TSST1 and TSST2. Long story short, ultimately what those toxins do is, remember we talked about interactions between like T-cell receptors and major histocompatibility complexes. So what happens is those toxic shock syndrome toxins take that interaction and they lock it where it's on all the time. That T-cell receptor and that major histocompatibility complex are locked. And that toxic shock syndrome toxin is what does the locking. So if that interaction is constantly on, your immune cells are releasing a whole bunch of cytokines. You get a cytokine storm, which ends up you eventually going into septic shock. So that's what those toxic, without having a bunch of diagrams and everything, that's ultimately what those toxic shots and those toxins do. They lock that interaction on, so you get a cytokine storm. For that reason, they're referred to as superantigens. There were some cases over the past 20 years where you would have someone that had they were menstruating, they would leave in a tampon for longer than what they should, and 100% of those cases were associated with that. So if you see somebody, they left in that too long, they have an infection, 100% of the time, it's from Staph aureus making these kinds of toxins. That is a board question I think that's been asked for the past 25 years. It's just something that's associated. Staph aureus strains can cause something else. This is in infants typically called scalded skin syndrome. Why do they make that? It's because they make a toxin that's referred to as an exfoliative toxin. What that means is that makes your epidermis exfoliate. If you see an infant that has this, it looks like somebody took a bottle of boiling water and threw it on. It looks like a very severe burn. If you see it histologically, it looks something. Again, my artistic skills are really crap, so we're going to be really cartoonish here. Epidermis, dermis. These should be together. If you look at a cross-section of somebody that has scalded skin syndrome, instead of these two being connected, there's a big clearing between them because the epidermis isn't attached to the underlying tissue anymore. So that's what scalded skin syndrome looks like. The way you test it just quickly in the hospital is you do something called a Mikulski sign. And what that is you take your thumb, you put it on the leading edge of some of the skin, looks like it's exfoliating, and you gently apply pressure, and you see if the skin bubbles up in front of your thumb. If it does, it's that. No, not that. It's that. This guy. That is not obviously very pleasant, but it's a quick way to tell if it's called skin syndrome. The skin will actually roll in front of the thumb. The odd thing about that is too, is you try to take a sample from actually where you see like the skin peeling up. You think you get some, like if you took a swab in there or something, you think you get some Staph aureus. You really don't recover the staph from that usually. You have to go to where it actually came from, which is usuly the umbilicus, around the umbilical, around the belly button, or in the nasopharynx, or potentially in the blood. You usually don't see it where you actually see the symptoms. If you try to swab that, you never get anything back. Okay, on to the different stuff. So, Mycobacterium tuberculosis and Mycobacterium leprae. So there are strains of Mycobacterium tuberculosis that are multiple drug resistant or extensively drug resistant. So multiple drug resistant versus XDR. XDR is going to be resistant to more antibiotics than MDR. Spread through droplet transmission, going to impact the lungs and lymphatic system. You end up getting these calcified tubercles to protect the bacilli. What happens is in your lung, because of mycolic acid and mycobacteria, your phagocytic cells, your lung macrophages, can't handle those cells, those bacterial cells. They can't phagocytose them, and even if they can phagocytose them, when they get them inside the macrophages, they can't break them down because of that mycolic acid. So what your immune system ends up doing is it just walls them off and essentially quarantines them in something called a granuloma. The granulomas, specifically in Mycobacterium tuberculosis, are referred to as tubercles. That's where tuberculosis name comes from. The tubercles, I guess technically, are something in tuberculosis referred to as caseous, which is a very fancy way to say if you take one of those granulomas and you cut it in half, it looks like there's cottage cheese on the inside. There are other types of infections that cause granulomas in the lungs that are non-caseating, which means they don't look like cottage cheese. But what can happen is when your immune system walls those off, those bacilli, well, they're still alive in there. So they hang out in there until what usually happens is, say, the person becomes immunocompromised later, and then those Mycobacterium tuberculosis cells start to come back and cause an active infection. So that's kind of how tuberculosis works. It's very hard to be able to treat tuberculosis because of the drug resistance to it, and also because sometimes people have these bacilli actually locked up in granulomas, so the treatment for it is usually a year or more, and it's called multi-drug therapy or combination therapy. That's what MDT means. Reason being, Mycobacterium tuberculosis becomes resistant to a lot of things pretty well. So what you do is you treat it with 2 or usually even 3 different drugs that all have different mechanisms of action. And the chances of it becoming resistant to all 3 of those drugs that have very different mechanisms of action is exponentially tiny. If you treat them with 1 drug, it ain't gonna work. The same thing holds true for Mycobacterium leprae. Leprae causes leprosy. Sometimes you see it in older textbooks, it's referred to as Hansen's disease. Armadillos carry leprosy. If you're exposed to an armadillo, you can get leprosy. Droplet transmission, it lives inside macrophages. You can get nerve damage, tissue destruction. That gets another one that you have to use combination therapy, and that's usually 6 months to 2 years, if not forever, because it is very slow growing and very hard to get rid of, so sometimes these people are on antibiotics forever. The kind of irony with leprosy is that, remember they used to have like leper colonies and stuff, people that had leprosy, because they were worried about it transmitting from one person to another. Leprosy is one of the least communicable diseases of the communicable diseases. It does not spread that easily from one person to another. You could almost lick one of these people that has leprosy and probably not get leprosy. It does not, don't do that obviously. It does not spread that easily. It is not one that spreads easily. You don't really die from leprosy. Usually, in my other classes, sometimes I'll list this as one of the ones that can be like a fatal disease. The reason it sometimes is a fatal disease is there's different forms of leprosy that can cause these aesthetic, hypopigmented kind of macules. I realize that's dropped like 5 terms that I'm done here. They can make these areas on your skin that are, you lose nerve sensation to. So just like somebody has, say, diabetes, and they lose sensation to their foot, and then they can get a real nasty infection in their foot and not really know anything's going on there. The same thing can happen in some cases of leprosy. They have a spot where they don't have nerve sensation, and something else gets in there, and that's usually the something that kills them, not necessarily the leprosy. That's why you sometimes see leprosy. It's like it's a fatal disease. It's usually not the leprosy, it's usually something else. How many people have had this PPD test in here? I would have to have this annually until I raised so much hell that they eventually caved and stopped doing it. What happens with this? is you have a protein called tuberculin, and that is made by tuberculosis. They are supposed to inject this just right underneath your skin, so you can get that little kind of bump there. If it bleeds when they pull the needle out, that means that they went too deep and they did it wrong, which happens 90% of the time. Another thing that happens with these is you're supposed to read the induration, which is a fancy way of saying you're supposed to see how wide the bump is. You can have a little teeny tiny bump and a red mark that looks like this. What people do sometimes is they'll measure the diameter of that redness. That doesn't mean anything. You're just looking at the bump. So sometimes you see somebody that measures the diameter of the redness and panic and think somebody has tuberculosis. It's because they measured the wrong thing. You're supposed to measure how big that bump is. Anything greater than 2 centimeters for a lesion is considered a presumptive positive. That's pretty big. Usually we measure this down into millimeters. 15 millimeters or so like a centimeter and a half is usually considered positive, regardless of any of those personal characteristics. What that means is sometimes as small as 5 millimeters is considered a positive result for somebody that doesn't have an immunological response. So if you have somebody that has AIDS and they have tuberculosis, but their bump's on like 5 millimeters, that's a pretty significant immune response for somebody that really doesn't have much of an immune response. So there are some different ways you read this, but anything less than about a centimeter and a half, definitely more than 2 centimeters, is considered positive no matter what their immune response is like. And then there's other tests you can do. You can look for antibodies against, you can look for the organism, you can do PCR tests or certain ways to test for tuberculosis. Okay. We talked about this one in here a little bit too. Causes ulcers in the gastrointestinal tract, so Helicobacter pylori produces a urease. That's one of the main ways it actually survives inside your stomach because your stomach acid is really, really low, around pH 2. What happens is Helicobacter pylori makes urease, which actually increases the pH and allows the Helicobacter to survive. Different ways to test for it. You can have them ingest things like labeled urea, labeled with carbon, and then what happens is the urease, as it works, it makes CO2. That CO2 is now going to be labeled, and you can see how much of that is being produced. The rule of thumb for things with Helicobacter pylori, there's a lot of people that carry this and they don't have ulcers from it. So if they're not symptomatic or they don't have some kind of a cancer that's resulted from this, you don't test them because most likely you ain't going to treat them. So if you're not going to treat them, you don't bother doing the test. This is the rule of thumb. It's generally passed on from caregivers and family to offspring. Carriers, there's a bunch of people that carry this are asymptomatic. There might be some of us in here that carry this and you might know we carry it. A lot of people have it and I haven't had any ulcers from it. About 50% of the population across the planet have it, about 30% in the United States, so this is something that a lot of us have. The person that actually discovered this, I think I talked about this too, his name's Barry Marshall. He grew this up and drank some of it. So that's how he won the Nobel Prize. Turns out it does cause stomach ulcers. Very rare. But that's Helicobacter. E. coli. There's more kinds of E. coli than what I'm going to bother you talking about in here. With the exception of these 3, there's about 3 other ones. These tend to be the more important ones. The other ones we don't know a lot about. The main one, I should say the main one. One of the main ones is something referred to as ETAC, anaerotoxigenic E. coli. Anytime you see that T, think traveler's diarrhea. Usually this happens, somebody goes to a different country, like say they go to Mexico, they're exposed to this, and they get watery diarrhea, referred to as traveler's diarrhea. This is usually the one causing it. So that's going to cause a watery diarrhea. So when you think T, it's really for toxigenic. When you see that T in ETAC, think traveler's diarrhea. Anaerobic invasive. This was pretty uncommon, at least in the United States. It multiplies inside intestinal epithelial cells, and the I in that stands for invasive. Again, you don't see that very much in the United States. The one you may see in the United States is another one down at the bottom called anaerobic pathogenic E. coli, or EPAC. Again, causes diarrhea, gets inside intestinal epithelial cells. You usually see this in younger kids. Usually if one person in the family gets it, the whole family gets it. A couple odd things about enteropathogenic E. coli. It does something called attaching and effacing. So attach to these intestinal epithelial cells, and then it will almost look like it's rubbing off the cell membrane on those intestinal epithelial cells. You'll see like little webs of the membrane coming off. So it attaches to them, and then like, it's kind of a weird way to explain it, it almost looks like it's taking like sandpaper to it, little blobs of the membranes coming off. That's what enteropathogenic E. coli looks like. Some strains of that can make something called bundle-forming villi. That's involved in the virulence, allows it to attach to these cells, essentially bundle-forming villi. Once those villi stick together, make a bundle, that allows it to stick to these epithelial cells. For whatever reason, people that are breastfed, again, this is little kids usually, infants that are breastfed, the mother's antibody in that breast milk tends to protect against this for whatever reason. The IgA antibodies in breast milk tend to protect against this. E. coli diarrheal diseases are usually transmitted fecal oral route, which we talked about a little bit. A little bit more about hemorrhagic E. coli or EHEC. So one of those ones we talked about before. It can make a Shigella-like toxin. So Shigella strains can make Shiga toxin. Shiga toxin can cause a condition called HUS. That stands for hemolytic uremic syndrome, which has three characteristics. It causes hemolysis of red blood cells, causes renal failure, and it makes your platelets tank. So the number of your platelets go down. Shiga toxin does that. E. coli can make hemorrhagic E. coli, can get the gene for those Shiga toxins and incorporate it into the E. coli and start making Shiga-like toxins. And what that does is it causes ultimately bloody diarrhea. That's why it's called hemorrhagic. An example of an hemorrhagic E. coli is 5787, which most people have heard of. The O in these refers to oligosaccharide, that's a component outside of the E. coli, and the H is referring to different types of flagella that the E. coli can make. That's all that means. But these are the ones that are going to cause bloody diarrhea. You have to watch treating with these. You have to watch even giving these people antibiotics, because if you give these people antibiotics, it can actually make the condition worse. It's the way the Shiga toxin is expressed. So there's different culture techniques you can use on just between the Shigella and the hemorrhagic. The reason it really tends to not matter very often is usually for a lot of these diarrheal diseases that are caused by bacteria. The treatment form is hydration, so you don't treat them with antibiotics anyways. But if it's bloody, people start to get a little concerned. If it's getting severe, because you usually treat with fluoroquinolones for Shiga or for Shigella, but if you treat hemorrhagic E. coli with fluoroquinolones in particular, what it does is those genes are encoded by a bacteriophage in E. coli, and what it makes it do, I think I'm going to talk about it. I don't think you realize maybe what context I was talking about it in. There's Shiga toxins in E. coli are encoded through a bacteriophage. So what happens is those genes are incorporated into the E. coli chromosome normally. But if you elicit a stress response, like you inject them with a bunch of fluoroquinolones, it essentially elicits a stress response in that E. coli, or technically the bacteriophage, and makes that bacteriophage go from a lysogenic phase, where the DNA is incorporated in the E. coli chromosome, to a lytic phase. So why does that matter? We talked about this before, we haven't talked about this yet. So you give somebody that has this, let's say 157, 87, give somebody antibiotics, that genetic material goes out of lysogenic phase and phase, and it starts making a lot of new bacteriophages, and it makes E. coli cells lyse. Why does that matter? The E. coli is gone now. Why does that matter? You got crap with E. coli in your gut. It's going to quickly become a Shiga toxin in your gut, producing E. coli. And E. coli is also a gram negative. What do gram negatives have a lot of on their outside? It can cause shock. Endotoxin. So it has LPS. The lipid A component of LPS is endotoxin. So you got a lot of endotoxin everywhere too. So bad, bad, bad. I mean, thankfully, like when I teach like the GI stuff and infectious diseases, most of those things, again, like bacterial, like gastrointestinal tract kind of infections, like the main treatments, give them a bunch of water or Gatorade. But, yeah, if it's bloody, you start to get worried. Your treatment options become a little bit limited and easy to goof up. Okay, salmonella. So this was a little bit weird to talk about the diarrheal diseases. So there are a ton of different salmonella species. There are a ton of different types of salmonella. But what they figured out over the years is essentially all those different types of salmonella are super duper closely related to one another, and they're not far enough distantly related to one another to give them individual species. So essentially what they did is they took all of them, and they're all Salmonella enterica, Cerebar, something else. So they're not identical, but they're not distantly enough related from each other where they can be individual species. So it is lumping them all in the same species, with the exception of one that they've been talking about lumping into enterica too, so don't worry about that. But so they all are called Salmonella enterica, Cerebar typhi, Cerebar typhimurium, Cerebar paratyphi, whatever. They're all kind of labeled like this. So most of these Salmonella enterica Cerebars are going to cause run-of-the-mill gastrointestinal tract kind of things, diarrhea. So you eat something that has salmonella, say from like chicken or egg or something like that, you get diarrhea. So that's regular kind of run-of-the-mill salmonellosis, you get diarrhea. The ones that do not cause diarrhea are the ones that are a little bit more concerning. Salmonella typhi causes typhoid fever. Salmonella enterica Cerebar paratyphi technically causes paratyphoid fever. They're essentially the same thing. There's another one called Choleraesuis that causes something very similar to. Essentially, they're all causing typhoid. What happens if you get infected with one of those is it doesn't cause diarrhea, it causes constipation, which is really unique for gastrointestinal tract bacteria infections. Most of them give you diarrhea. There's not a lot of them that give you constipation. So the other thing you see with that too is you see these people oftentimes they have these little pink kind of spots on their body. That's what we call rose spots or salmon color kind of little dots. You see that with these two, typhoid fever and paratyphoid fever. So again, those two are going to cause constipation as opposed to diarrhea with the rest of them. You should see these from fecal contamination of water. You do not see this in the United States very much because we're very fortunate. We have really good wastewater treatment and water treatment facilities here. Usually the salmonella cells tend to get in from the lumen of your gastrointestinal tract into your body through these M cells we talked about before. Remember that those M cells sample, they transcytose those bacterial cells through the M cells. On the other side of the M cells, there's usually some kind of immunological cells underlying those. Salmonella has figured out a way to find its way around those immune cells and cause an infection. Sometimes you get a salmonella infection that actually goes and gets into the bloodstream. And if it gets into the bloodstream, it can cause a really nasty infection, especially in people that are asplenic, because people that don't have a spleen do not handle bacteria that have capsules very well, because that's where those are cleared by your system. And salmonella makes capsule. So they tend to have pretty nasty infections. They're very small. Some other bacteria, and I promise we're getting through these as fast as I get through them. Streptococcus mutans is responsible for forming plaques in the mouth. It can cause, tooth decay, cavities. There we go. It can form plaques and cause cavities. It makes a sucralase or a sucrase that breaks down sucrose. It also can produce different acids, acetic acid, lactic acid, and that can result in tooth decay. The problem with this is, we talked about this a little bit before, is a lot of the flora that's in your mouth is fine if it's in your mouth, but if it gets to other places in your body, it can cause some really nasty infections, and strep mutans is one of the ones that does that, and it can get to your heart and cause endocarditis. If you have somebody with very disease. Another one. Clostridia tetani causes tetanus, usually finally associated with the soil. Usually that's through some kind of a puncture wound, you can get it into your system. It doesn't like oxygen, so it requires low oxygen to cause tetanus. gets inside the wound, deep in the wound where there's not a lot of oxygen present, and then it produces tetanospasmin, which is the toxin, and also tetanolysin. Essentially, those are the ones that cause tetanus. Most of the tetanospasmin is the one that causes the effects of tetanus. Tetanus causes a generalized spastic paralysis, which means it makes all the muscles in your body contract. So it causes tetanus. And that is prevented by the T and the DTaP vaccine. So that vaccine protects against the toxin. So it has an activated toxin. This is what somebody with tetanus looks like. All their muscles contract. Not a fun way to go, unfortunately. There are different treatments for this. We'll talk about a little bit about them, but you can try some different treatment options for that. Usually for tetanus, you can give an antitoxin that tends to alleviate some of the symptoms. You can give antibiotics. There's been, if it's in a wound, there's been some, I think I have this up here somewhere. I can't remember where I put it down. But there's been some success with using things like hyperbaric chambers where it forces oxygen into those deep wounds. Kill it that way. There's different ways to treat. Botulinum, we've talked about a little bit before. Clostridium botulinum, you see in adults, it's usually from canned food, causing intoxication illness. There, once upon a time, in those canned green beans, there was some Clostridium botulinum. Those have since died off, but the toxin remains, and when you consume the green beans, you ingest the toxin, and then you get botulinum. So botulinum causes a descending classic paralysis. Again, it goes down your body, eventually hits your diaphragm, and then those people can't breathe. So somebody comes in with botulism, you have to watch them and make sure that they can breathe, and if they look like they're having difficulty breathing, you have to intubate them, put them on a mechanical ventilator. In infants less than 12 months of age, usually they tend to get botulism by people feeding them honey, because you find Clostridium botulinum associated with honey. It's associated in nature with beehives and honey. I swear I'm always going to look this up, and I never do. I used to teach and I forget what it is. There's something with the oxygenation of your gastrointestinal tract in infants versus adults. If we consume honey and it has Clostridium botulinum in it, our gastrointestinal tract has more aeration, there's more oxygen that gets through it or something, and the Clostridium botulinum can't grow. But in infants, it tends to be more anaerobic and it can grow. So you actually don't see any intoxication illness with infants. You see a toxico-infection where you actually do have Clostridium botulinum there. It is actually multiplying, and as it multiplies, it's also making toxin. So it's a toxico-infection. I cannot remember the path is behind that. It's been then, but it's something to do with the oxygenation of the plasma. What it does in infants, it colonizes and grows in the baby's intestine and causes something, it's crass as it sounds, referred to as floppy baby syndrome. So it causes all the muscles to relax, and if you hold the infant in your hand like this, they droop over your hands like a wet rag. Sometimes some of the terminology we use is not the nicest, but that's what floppy baby syndrome means. So they just lose all muscle tone, and that is exactly what it looks like. Yeah.
So, like 2 years ago, I think, one of my aunts, she had her first kid, and the baby, he was like, I think 7 months, and she gave him like caviar to try, because it was like, oh, can you get like a toxin? Because he was sick in the hospital, so like, took that long to get a toxin of that sort, or, and I was just
I don't know what's in that.
Yeah.
I don't know what's in that. I have no idea what would be in caviar.
Because I was curious if it would fall like under the same, like,
I mean, it is tan, typically. I don't know if you see botulinum. Maybe. Is that what they act like?
just the baby was just in pain, he was crying 2 hours after.
There's probably something else that was in it, but I don't know what it would be. I don't know. I don't consume a lot of caviars. I have no idea what's in that. I mean, usually things associated with like salt water, you find in Bacterial. But I mean, that's not necessary. Yeah, I don't know. Perfringents, you find associated causing gas gangrene. You usually get that in the soil too. Somebody has some kind of a penetrating wound. they get Clostridium fringes in it, causes gas gangrene. You can use hyperbaric oxygen for that as well. You can see this sometimes causing food poisoning as well. Again, you see it associated also with green beans, and in this case, the fringes can cause a toxic infection. This is what wound botulinum looks like when you get a wound. This is what it looks like in animals. You can see how this was actually in ducks that were exposed to botulism toxin, and it's exactly like I kind of explained with babies. They lose all muscle tone and they just droop over their hands. So it impacts a lot of different animals, not just us, in a very similar way. What gas gangrene looks like, so called gas gangrene because acid actually causes tissue necrosis and makes gas. If you see something like that, like this person's going to lose this toe, probably that toe, maybe part of these other two toes. And what happens is these microorganisms, as they get in there and they cause necrosis of tissue, damage to the tissue, the bacteria can actually start to use that dead and decaying tissue as food because there's nutrients in it. So when we talked about, what are we talking about in here? We talked about the antibioticic fatty acids last time. I said they did like an debridement where they take off all the dead and decaying tissue. Same thing for this. There's another picture showing a different class where essentially all there's necrosis in all of the toes and starting to go up the foot. And essentially what you have to do is like amputate. I mean, that's how you can't do anything with this tissue to put on. And if you leave that, it's going to let the organism grow more. So you have to get rid of it. So that's what gas gangrene is. Some other kind of oddballs. Lyme disease is caused by an organism called Borrelia burgdorferi, named after Willie Burgdorfer, which passed away here a few years back, but Willie was the one that actually described the vector for it, at least the tip. There are some other minor species that literally I've never seen anywhere. Usually it's called because of Burgdorferi. Key features of the bullseye rash, which you can see up there. There are other ways that rash can present where it doesn't necessarily look like a bullseye. It causes an undulating fever, which is exactly what it sounds like. It means the fever goes up and down, and up and down, and up and down. There's not a lot of bacterial infections that can cause an undulating fever, but Lyme disease, Borrelia infection is one of them. It can cause an arthritis. If it's left untreated, it can cause different neurological conditions like dementia. The reservoirs for it are deer mice, and the vector for it is a tick. Antibiotic therapy is pretty effective against it. The main way we control against it is tick control. If you get bitten by a tick, to make sure you get it off your body very quickly. Anything over about 48 to 72 hours. If you're bitten with a tick and the tick is feeding on you for more than a day or for 2 or 3 days, the chances of you getting Lyme disease go from like 20% to like 100%. So you have to get it off within 2 or 3 days. Anything past 72 hours, you might as well just leave it because you've got Lyme disease. Not communicable because it's transmitted through the tick. You can have long-term symptoms that last after Lyme disease, after Borrelia infection is actually gone. Different kinds of reactive arthritis, disease. At this point, antibiotics don't help because the immune response is actually the immune system's doing it. There's not Borrelia up there. Borrelia is one of the ones that has a kind of odd shape to it. It's a spirochete. So remember, it's got that corkscrew shape to it, just like, you can see what these look like. Just like syphilis and most other teeth. What Lyme disease looks like: localized stage 7 to 10 days after infection, bullseye rash. It can disseminate, get into the central nervous system, get to the heart, cause arthritis. If left untreated later in the person's life, they might get things like MS or Alzheimer's disease, and treatments with some different antibiotics, 14 to 21 days. If they have central nervous system signs, we usually treat them longer. Usually a treatment for anything that's weird that causes odd symptoms is usually doxycycline. For whatever reason, if it's on, causes odd symptoms, doxycycline usually works for it. Lyme disease, doxycycline can work for them. There are other treatments for doxycycline, is one that will work. For syphilis, which is another spirochete. Does anybody remember how spirochetes move? What do they move? What kind of flagella? The endoflagella. So they're in that periplasmic space. Flagella are actually, they're not external, they're inside. They move past one another. As they move past, it allows them to turn. So they burrow down the skin like corkscrew or tissue, cells, whatever. That's what makes them turn. 3 stages of syphilis, treponema pallidum causes syphilis, so that's an STI, it's communicable, 1 or more sores that last 3 to 6 weeks, this is usually how this starts. Usually that's only 1 sore, it doesn't hurt, and it is referred to as a chancre, not a canker, it's a different kind of sore. So you have usually 1 painless chancre. Stage 2, sore heals. Stage 3, it can lay dormant for up to 40 years. Why 40 years? Because we have demonstrated this lasted longer in a leading time period, more than 40 years, because of all the data we have. It probably could last longer than that. And then it can go into a different stage 10, 30 years after the infection, where it can cause things like neurosyphilis and involvement of the eye, causing ocular syphilis, organ failure, can cause all kinds of things. Syphilis, depending on the stage, usually stage 2 is referred to as a great imitator because it has a lot of kind of nondescript odd symptoms that people misdiagnose for other things and treat it like it's not syphilis. They might have a rash, they might have desquamation on their palms and the soles of their feet where the skin's peeling off. There's like all kinds of just kind of weird symptoms that syphilis can cause, and it makes the diagnostics, the diagnosis kind of hard sometimes. So that's kind of where syphilis is weird. Usually you treat syphilis with penicillin. If you have somebody that's allergic to penicillin, the treatment is doxycycline. Like I said, it's weird, bunch of symptoms, doesn't make any sense. Doxycycline about 95% of the time works. I have no idea why that is, but that is a fact. You don't really get immunity to that. So if you have syphilis, you take penicillin, you get rid of syphilis, you can get syphilis again. Syphilis is kind of an odd one because it has a periplasmic space where there's endoflagella so you would think it's gram-negative, but it's not really gram-negative or gram-positive. It's like distantly related to both of them. So it's kind of, the spirochetes are kind of a random little odd thing. And then lastly, thank you for bearing with me as I go through like the auctioneer version of bacterial infectious diseases. Legionnaire's disease, so Legionella pneumophila is one of the most common ones. You find this associated with water, usually in cooling towers, fountains, sometimes even along springs and streams and things like that. It becomes airborne, it can live in protozoan, you inhale it, and then you get Legionnaire's disease. There's about 25,000 cases of that a year, about 4,000 people die. There's a less severe kind of form of that called Pontiac fever. It's more flu-like, tends not to be as severe, but they're all caused by Legionnaire's disease. There's another species called Bacterial, named after Joe Bacteria, because Joe's the one that discovered it. Yeah, usually find it associated with water. This is the one why I said they don't have drink, or they don't have water fountains inside the bodies of hospitals. This is the main one why, because if it gets more water, everybody that walks in gets aerosolized Legionella pneumophila or Bacterial or whatever species you're talking about. Gave everybody Legionnaire's disease then, so they opted to not do that anymore. So you don't see a lot of fountains in April. Okay. That took way longer than I wanted to, guys. Do you want to talk about the exam real fast?
Yeah.
Because that's going to give you a ton of time to study for the 4th one, which is kind of why I did this.